Go ahead.
Hi, welcome. My name is Barbara Cochran. I am the director of the Deternier Center for Healthy Aging, and I'm representing the Northwest Geriatric Education Center today for this next lecture in our Geriatric Health Lecture Series. I do want to mention again that if you want continuing education contact hours, you can log on to the website, and your site coordinator should have that information available. So you don't have to write checks or anything. You can just do it online. Also, these lectures are being posted fairly rapidly after they're presented on the Northwest Geriatric Education Center website. That's nwgec.org. And so if you know of people who've missed the lectures and are interested, feel free to give them that web address. And today I'm very happy to introduce a colleague, Rebecca Logsdon. She's a research professor in the Department of Psychosocial and Community Health in the School of Nursing. She holds an adjunct position in psychiatry and behavioral sciences in the School of Medicine. She's a clinical psychologist specializing in gerontology and has worked with older adults with memory loss and their families for over 20 years. She's on the faculty of the CDC Prevention Center's Healthy Aging Network and is a fellow with the Gerontological Society of America. Her research is focused on neuropsychological and behavioral functioning and psychosocial interventions for individuals with memory loss and their families. And she's currently principal investigator of an Alzheimer's Association-funded grant that's evaluating outcomes for early-stage support programs and co-principal investigator of an NIA-funded investigation of physical activity interventions for individuals with cognitive impairment. Other ongoing research studies include a very interesting project looking at participant outcomes of an experiential arts program at the Frye Art Museum here in Seattle, evaluating and developing procedures for resolving methodological issues in treatment outcome research with dementia patients and caregivers, and assessing quality of life in individuals with dementia and their caregivers. And today she's going to be talking about evidence-based community support programs for early stage dementia. Welcome, Rebecca.
Thanks, Barb, and I'm really happy to be here, and thank you to my live audience who came to see me in person, but also thanks especially to all of you in the far-reaching areas. I'm really excited about the number of sites and places that we have participating in this today. I'm going to be, as Barbara said, I'm going to talk to you a little bit about what we know from research and clinical practice about support programs for early stage dementia. And this is a new talk to this series, which I haven't done before, so I think it'll be interesting. And it also is the talk that is probably closest to my heart of any of the things that I've been doing lately, because I think working with early stage dementia programs is really very rewarding and interesting and challenging. Okay. There we go. First of all, I just wanted to talk a little bit about early stage diagnosis, which is kind of a new phenomenon in the last 10 years or so. We've developed technologies to be able to identify and diagnose dementia and Alzheimer's disease earlier and earlier in the course of the disease. And what we have found in clinical practice and in our research is that people who are diagnosed in the early stages live with the disease for many years, but it is a life-changing diagnosis. Nothing is really quite the same after that. And there are both positive and negative impacts to being diagnosed with dementia in the early stages. Positively, it can facilitate the initiation of, I'm going to scoot my chair up a little bit, of medical treatment and help people to begin their legal and financial planning while they're still able to participate in decision making. And it can help both individuals who are diagnosed and their families initiate and mobilize support services early in the course of the disease process. So there's a lot more opportunity for the person with memory loss to participate and express their wishes, which is really good for both the person and their family to have those kind of laid on the table in the very beginning. there are also some negative impacts to being diagnosed early in the course of dementia. One of the first things I think that people talk about is anxiety about the future. What's going to happen to me? What should I expect? How will this change my life? And so that's one of the things that people face when they receive this diagnosis. Many people talk about negative stereotyping, that, you know, once you're diagnosed with dementia and people find out about it, they start assuming that you cannot do things that you really are able to do or think that you should be able to do. And then it also can have an impact on relationships with other people because of that. So family members, friends, others may start treating the person with the diagnosis a little bit differently because of that diagnosis. And so both positive and negative aspects to being diagnosed with dementia. And it is my belief, after about 15 years of practice in this area, that early stage services that are provided at the time that the diagnosis is made can really alter the experience of the disease and the quality of life for both the person who's diagnosed and the people who are caring for him or her, their family members or other caregivers. I have started thinking, and I think more and more clinicians and others have started thinking about dementia as a chronic illness. So rather than a terminal diagnosis, which it is, but it's such a long-term process, the decline in cognitive functioning, especially when it's diagnosed early in the process, that it really is in many ways like chronic illnesses that older adults face. And again, like I said, we really have found that focused health promotion strategies can alter the experience of that chronic disease. This is a definition of quality of life, because that's really kind of the crux of my talking today. Is the goal of all of the things that we've been doing with our early stage services is to find ways that we can help maintain quality of life for both the person who's diagnosed and for their family or other people who are caring for them. And this is a definition that I found back in 1986 when I really first started thinking about quality of life and dementia. And, you know, it was kind of a new topic at that point. And this is from the Institute of Medicine. I'm not going to read the definition to you because I know you have it there in front of you. And I'm actually going to kind of break it down and talk about how I think this, even though it wasn't originally intended for dementia, I think that it applies to people who have dementia. So here's how I think it applies. One of the crucial factors in quality of life is a sense of well-being. Well, with people who have dementia, we can help to maintain a sense of well-being throughout the entire course of the disease by helping to treat depression and excessive anxiety, by trying to make sure that they're free from physical pain, and by providing a feeling of safety and security for people that whatever happens, we can deal with that. So that helps to foster that sense of well-being. A second crucial important point to quality of life in that definition is satisfaction with life. And so with dementia, what does it take to be satisfied with life? Well, many people have preferred living arrangements, and that's an important aspect of satisfaction. Being engaged in meaningful and pleasant activities throughout the course of the disease is important. And then maintaining participation in family and social activities is also a value that most people have. Self-esteem, recognizing the contributions that people have made both currently and throughout their lifespan. Many of the people that we work with who have dementia have had very productive, outstanding lifetime achievements, and to not forget about those, but to remember those and to remind people of those even as the disease progresses and they may forget about them. And then being respected by other people. And then it's achieved through these three things: the care received, so getting an appropriate level of assistance and having it provided in ways that are acceptable to the care recipient. So having choices about how your care is provided and what kind of care you get. Achieving desired goals, so recognizing that people do have preferences, individualizing care, and then maintaining a sense of control over your life. I think that's one of the things that people fear slipping away, is that feeling that you have control over what's happening to you. So I think it's important to engage people in decision making, to give them alternatives to choose from. And again, these are things that I think that we can do throughout the course of cognitive impairment. And I think that beginning in the early stage makes it much smoother to do that along the way, because people can engage more actively in many of these decisions. So based on that, we really started off with 3 research questions, and it's really the third one that's the most important one. What can we do to improve quality of life for people with dementia? But in order to answer that question, we had a couple of things we had to do first. First of all, we had to just figure out, how do you even begin to evaluate quality of life in people with dementia? And then the second question is, well, what is it that influences quality of life in dementia from the person's perspective? So I'm going to walk through the first 2 questions pretty quickly and then spend more time on the answer to the third question. And this is, I have to tell you, this is a pretty researchy talk, because I started off my career as a clinician, and then I became more and more engaged in research. And I really think that that interaction between clinical knowledge and research is very important. It's very interesting, and it's really what drives our work in this area. So, but I promise, bring it back to some suggestions and clinical ideas and things that you can do with your clients or patients that we have learned because of these research studies. So first question, how can we measure quality of life in individuals with early stage dementia? And again, this was back when we started thinking about this in 1986, 1990, and that time frame. And at that time, the main way it was done was by asking healthcare providers to rate quality of life for people that they were taking care of, their patients. But when we started looking at quality of life and talking to the actual people whose lives we were evaluating, we often found that the healthcare providers, the family members, and the person whose life was being evaluated had different ideas about what was important and how they would rate quality of life. And so some other strategies have been developed, both using direct observation and looking for the kind of signals, the body language and other kinds of signals that would denote good quality of life, by having caregivers or family members rate quality of life. And then I think most importantly, by having the individual be able to self-report what their quality of life is. And since then, there have been many different measures that have been developed to assess quality of life in people with dementia. And as you look down the list, you'll see that it's really a combination of all of those different strategies. The measure that we developed here at the University of Washington is this one. Yeah, you can see my pointers. This one, the QOL-AD, that was really developed for people living in the community with mild to moderate dementia. And it's designed so that there's a self-reported rating by the person with dementia and a proxy rating by their care provider. So we can get both perspectives. And other people have done the same thing. And, you know, I think that which of these measures you would use just kind of depends on what your purpose is. Many of them are pretty good. But the one that I'm going to be kind of basing some of my talk on is the QOL-AD. And one of the reasons that I like it and other people have liked it too is that it's pretty short. It's only 13 items. It's easy to respond to. So people with moderate dementia can still respond to these questions reliably and with validity. So it's got good psychometric characteristics. So using that particular measure, because it was one of the earliest and it's one of the most efficient and good psychometrically, we started looking at the second question, which is, well, what is it that influences quality of life for people who have dementia? Looking at it from the diagnosed person's perspective. And so the next step in our process, in our exploration, was looking at what is associated with, PWD stands for person with dementia in this chart, and CG stands for caregiver, and these were family caregivers in this particular investigation. And so we looked at, from the perspective of the person with dementia, what other things were associated with their quality of life ratings. And the number one thing was depression. If people were depressed, they rated their quality of life lower. The second thing was activities of daily living, the ability to do those day-to-day activities that are so important to all of us in our routine activities. And then the third one, from the perspective of the person with dementia, was the ability to engage in pleasant events, to do enjoyable, meaningful kinds of activities. And on this chart, you'll also see there's a caregiver rating, and this is the caregiver proxy rating, so they're rating the quality of life of the person they're taking care of. And again, the number one factor that influenced that was the depression in the person with dementia. But it was a little bit more complicated from the caregiver's perspective. Physical functioning, the cognitive status on the mini mental state exam, and pleasant events were also part of that mixture. But these two things I think are particularly interesting. Caregiver depression and caregiver burden influenced the caregiver's perception of their care recipient's quality of life. So a person who's feeling high levels of burden or depression is likely to rate their care recipient's quality of life lower as well. So this was one of the things that we used to help us to identify, well, what kinds of treatments would we do, or how would we intervene to improve quality of life for this person, the person with dementia. And we also looked at it longitudinally over time. We followed a group of people for 6 months, every 6 months for up to 5 years, and then we looked at what was associated with changes in quality of life over time. And what we found was that for the person with dementia, if their rating of quality of life declined over time, it was associated with higher levels of depression and less productive activity, so less engagement in meaningful activities. For the caregiver's rating of the person, of decline in the person with dementia, it was associated again with higher depression, with more memory problems and behavioral kinds of memory problems, like losing things or forgetting things, not memory problems as measured on cognitive tests necessarily, and then less physical mobility. So you can kind of see a picture emerging here of what's really essential to quality of life for people who have dementia. And in fact, it emerged not only in the work that we were doing, but in other studies looking at quality of life as well. So you can see here there's just a list of other researchers who have explored this same thing. And really the pieces of the puzzle are pretty consistent across all of those studies. It's mood, it's mobility, it's memory, particularly memory for functional tasks, and it's caregiver burden. And so those are the 4 pieces of the puzzle that we really kind of teased out to work on in developing psychosocial and community-based interventions for these individuals. So that leads us to the third and, as I said, most important question: what can we do to improve quality of life for people with dementia and for their caregivers too? So again, the psychosocial treatment implications are that we should develop strategies to help maximize social and ADL functioning, ADL meaning activities of daily living, treat depressive symptoms and encourage pleasant activities, improve or maintain physical mobility for the person with dementia, and then finally to support caregivers to reduce their levels of depression and burden. All of those were the things that are associated with quality of life. And over the years, there's really developed an evidence base to address all of those different areas. And these are, what I have listed here are randomized controlled trials that were done in each of these areas by different researchers. And I listed the name and the date of those studies so that if you want to, if you're interested in any of these particular areas, it's pretty easy to track those down looking on Medline or PubMed or some other search engine. But I just wanted to point out that there are many psychosocial interventions that have been demonstrated to improve these areas of functioning for people with dementia. And these are people at all different stages. It's not just early stage. So, but now I want to kind of go into a little bit more detail about each of those areas and talk about examples of what we can do and what we know about people with early stage dementia and how to maximize their functioning. So starting off with the social and ADL functioning, I wanted to tell you about early stage support groups, which, as Barb mentioned when she was introducing me, this has been an area of research that I've been engaged in for about 15 years now, in conjunction primarily with our Alzheimer's Association chapter here in Seattle and Western Washington. And they have actually had an early stage support group program for probably 20 years. And I started working with them at the very beginning, and we were able to get some funding both from the National Alzheimer's Association and then from the National Institute on Aging to really start to look at what are the outcomes of these early stage support groups. And so that's what I wanted to tell you a little bit about those first studies that we did. The early stage memory loss seminars, which is what our Alzheimer's Association chapter called them at the time, seminars rather than support groups, because people were more willing to participate in a seminar. And what we did, because when we developed the research study, is that we developed an annual facilitator training so that we had some standardized training across these volunteer facilitators, because our groups were all over Western Washington and the facilitators were all volunteers. We also had a structured manual with an outline and what topics they should discuss at each session, and we had handouts for people that they could hand out at the session. And then this just lists the content of all of the sessions. So you can see that the groups covered many different things, from coping with memory problems to the medical issues to family and legal issues. So it was kind of a basic intro to how to cope with dementia and what you need to do to plan for the future. And in assessing the outcomes of this group, we looked at a variety of different areas. We looked at that are all listed here, so I won't read them all to you, but we were particularly interested in whether these groups had an impact on quality of life and mood, because those were kind of the two things that we thought were most likely. And in the study that we did, it was a randomized controlled trial where people either went to an early stage support group or they were assigned to a wait list for 6 months. And so then we evaluated everybody after that. And this just gives you the demographics of that group. You can see it was early stage people. Their average mini-mental scores were about 23. They were primarily white, but there was a small mixture of other kinds of ethnic groups. And most of the care partners in these groups were spouses, which is one of the things that's kind of changed a little bit over time, but this group had a particularly high number of spouses engaged in it. And the way the groups worked were the person with dementia and their caregiver would meet together for part of the time. They were usually 90-minute groups. They'd meet together for part of the time, and then they'd each split off into separate groups. So there was a group for the person with dementia and a group for the caregivers that were separate. So they required 4 support group facilitators because we wanted to have 2 people in each of the groups at all times in case there were any problems that came up or anything. So fairly labor intensive, but people's responses to the groups were really good. And I'm going to just show you really quickly some of the outcomes that we found. This is quality of life, and up higher on the bar, my arrow disappeared, but going higher is better. This is where people started at baseline before they were in a group. And the people who were in the early stage groups had an improvement in their quality of life. And the people who were in the wait list condition had a decrease in their quality of life. And this was a significant difference between those two groups. We also found for depression, people who were in the support group stayed about the same over time on their depression scores, and they were not a very depressed group to start off with. People who were on the wait list tended to get a little bit worse over time, and again, this is a statistically significant difference. And we also looked at people whose quality of life improved and looked at what else improved along with that, because again, we're always kind of interested in, well, so what's the clinical significance of that? What difference does it really make in their day-to-day life? And we found that for people whose quality of life improved, their mental health also improved, their feeling of self-efficacy or feeling of self-control improved, and their family communication patterns improved. Their feeling about how they were communicating primarily between the primary caregiver and the person with dementia. And those were all our strongest relationships. We also saw a decline in perceived stress, in other kinds of depression scores, and in behavior problems in general. So it's looking like being in these groups and having that change in quality of life does have some clinically significant differences or changes, implications for the people. And then we also asked people, what did you think was the most beneficial about this group? And the darker bars are what the caregivers identified. No, the darker bars are what the participants identified, and the lighter ones are what the caregivers identified. And so you see what the participants were saying, and this is still what we find even now in other kinds of groups, is, it's the feeling that they're not the only person who's going through this, that, here are other people like me who are having the same kinds of problems, and we can talk about that. And so that social support and decreased isolation. For caregivers, those were important, but also the information that they got from the groups they found very helpful. So legal information about community resources, about caregiving, those were things that they also identified as being important. So that's my example for social functioning, what kinds of things we can do to help to improve social functioning. Treating depressive symptoms and encouraging pleasant activities, as you can imagine, is really important, since you remember that when I showed you what was associated with quality of life, depression was the #1 thing. And this is a study where we looked at a depression treatment study it was a behavioral treatment for depression, which really focused on identifying and helping caregivers and people with dementia engage in more pleasant activities. So what happens when a person has dementia and starts to have memory problems or difficulty with complicated tasks or hobbies that they might have done is that they kind of tend to start dropping those things off. And if they don't find something to either modify those activities so that they can still do them, or something that they could replace them with, they end up with not very much to do during the day. Those of you who work with or have a family member who has dementia probably have noticed that that's one of the hardest things to deal with as a caregiver is, well, what can I do? How can I engage my family member in activities? And so this was our first attempt to try to develop some of those activities. And it's our belief that individuals who have dementia retain many skills despite having cognitive impairment. And if we can identify those skills, then we can identify things that they might enjoy doing or might be able to do. We also have found that interpersonal relationships are very important, and they're fostered by shared activities. A lot of times caregivers, even very early on in the progression of dementia, even in the early stages, can get into kind of a constant negative interaction with the person that they're caring for. So, always being the one who says, well, no, did you remember to take your pills, or have you paid the bill yet, or oh, well, don't you remember Alice called us yesterday? And, you're just kind of always in this kind of negative or confrontational communication style. And by identifying pleasant activities that both can engage in together, you change that personal interaction, or you can kind of intervene in the negative interactions and create some more positive interactions in the relationship. And caregiver depression and burden can also be decreased, focusing on positive rather than negative interaction. So it's good for both the person with dementia and for the caregiver. There's a scale that we developed because we wanted to be able to identify pleasant activities that were common for people with cognitive impairment. And it's called the Pleasant Event Schedule. And it's been used in pleasant event schedules of different variations have been used in depression treatment for people of all ages. This one we tried to make specific to people who had Alzheimer's disease or other kind of dementia. And we wanted to include a variety of items, so social activities for people who like that, non-social activities, solitary, active or passive, more or less complicated activities, and some things that require more or less supervision. You know, it's nice to have some things that people can just do on their own without having to be instructed on how to do it. And you know, you can see the pictures here that illustrate some of the kinds of things that can be incorporated into that. Many people find eating or having food together to be a pleasant activity. Walking or physical activity. This is my mom, who herself had vascular dementia and passed away 5 years ago, but it was a 12-year process. So we went through the whole cycle of cognitive change with her. But you know, this is where she was severely dementia. She didn't remember who I was when she was holding her grandchild here. And then identifying and reintroducing those pleasant activities. So how can we do that? And this is part of the take-home message for you who are clinicians who might be working with clients or patients or family members in the community. And these steps can apply to people at any point during the progression of dementia, but it's a lot smoother if you can start doing these things early on and just kind of get into that pattern. So looking at what the person enjoyed doing in the past. What is it that they enjoy doing now, and or that they might enjoy doing now? And how can tasks be modified to accommodate current abilities? I'll use my mom as an example. She did china painting. That was her hobby that she picked up when she retired from being a teacher. But china painting is a multi-step process. It involves multiple firings of the china after you add layers and layers of paint on it. So it was one of the first things that she kind of dropped out of doing it. It's actually one of my first clues that there was really something wrong. And so I started looking at, well, what else could we do? Watercolor is easier than china painting. It's because it's only one step. You can do it, you can sit down and do it in one step. So just identifying how can we modify things that people like so that they can still do them. For people, I've worked with people who like to do quilting, and even when people lose the ability to use the sewing machine and plan and design a quilt, sorting fabric is still really fun. I mean, all of us who do any kind of sewing like to do that anyway. So, you know, having a basket of fabric can be a really pleasant kind of thing. And my favorite example is one guy that I worked with was a caregiver for his mother, and she loved to iron. Only person I ever knew of that liked ironing, but he was worried about her using the iron, and so he figured out how to modify the iron so that it would get warm but not hot enough to burn anybody, and so she could continue to do her favorite activity. So that study, where what we did, the treatment was to identify and implement pleasant activities, to work with caregivers, taking care of a family member at home, to identify and carry out pleasant activities, had a significant impact on depression in the care recipients. And this impact was as much as we had found 2 years earlier in a drug study with antidepressants, and no side effects and no dropouts. So you can see here that for the people who were in the pleasant events condition, 60% of them had a clinical change where they got better, meaning that those who had major depression did not have major depression after the end of the study, or those who had minor depression did not have minor depression. So looking at that. And about the other 40% were the same. They hadn't changed. They hadn't gotten any worse. Where in our control condition, who got the same number of sessions of just generic counseling with social workers, had only 20% improvement. Most of them were still the same, and then a small number of those had actually gotten worse over time. And this is their Hamilton Depression Rating Scale scores. And what you can see here is that there was a significant decrease in the people who were in the pleasant events condition. This was people who were in treatment as usual, where they saw the counselor every week, and then this was a wait list. And so again, you see that the treatment, the specific targeted treatment on pleasant activities really had a significant impact on depression scores. And then this was a bit of a surprise to us. The caregivers, we also evaluated caregiver depression levels, and the caregivers were not as depressed to start with, but we had a significant number, again, you can see this, that had either major or minor depression in this group. And for those who were in the treatment and doing the pleasant activities with their care recipient, their depression improved as well. So both the patient and the caregiver depression went down. And again, the control conditions, the caregivers stayed about the same. So the next area was looking at improving or maintaining physical mobility. And here we're talking about the ability to get around. We're not talking about strenuous exercise, but just the ability to move around in the community. And in clinic, I had a caregiver once who said, "I'll be so glad when my husband can't walk anymore because it'll be so much easier. I won't have to worry about him wandering out of the house." And I said, well, when somebody can't walk, think about what that means. Think about how that increases your own burden of caregiving. And in fact, losing mobility is often what's associated with people moving from home to a nursing home because they've fallen and broken their hip, or the caregiver just can't lift them and help them with transfers anymore. So when we started talking about that, she changed her mind about that. So there are many benefits of physical activity, and we hear about them every day for all of us. We all benefit from physical activity. They apply just as much to people who have dementia as to everybody else out there, all of the rest of us. And there are researchers who have demonstrated that physical activity programs can help to improve strength and mobility in people with dementia. They can reduce depression. They can decrease behavioral disturbances, so agitation or other kinds of behavioral disturbances, particularly as dementia progresses. And there are some studies now, and actually an increasing number, I need to update my slide, that exercise can actually help mitigate cognitive decline, so that not only is exercise useful in preventing vascular changes or other kinds of problems that are associated with cognitive decline, but we also, in people who have normal older adults, or people who have mild memory loss, we can see improvements in cognitive abilities. Despite all of that, we know that if any of you have tried to do exercises with people who have dementia, you know that there are some challenges that people face with that. And the reason why people who have dementia don't exercise much is because sometimes it's just really hard to get them to do it, or hard to figure out how to make it happen. A lot of times people are reluctant to try new activities. You know, it's if they haven't been an exerciser before, it's hard to get people to start doing something new. They may have difficulty learning the exercises and remembering to do the exercises. One of the examples that I always think about when I think of what it's really like for a person who has even mild memory loss or early stage dementia to do an exercise program like in a group, like going to Enhanced Fitness or a group exercise program at the gym is, you know, if you think of yourself, and if any of you have ever gone to an aerobics class, the first time you ever went and you kind of stood on the back row and watched as people were doing these complicated moves and thinking, oh my gosh, I'm never going to be able to do this. But, you know, if you keep going, you learn those and it comes back to you. But if you have memory loss, it's like the first time every time. So who wants to do that? There's also concern about safety, whether it's safe for people to either to go out walking in the community alone. At some point that becomes unsafe. And also whether people can use exercise equipment safely, because it's easy to injure yourself if you use it incorrectly. And then another challenge for family caregivers is that they themselves, especially in the generation now that's in their 70s and 80s, they may not know much about exercise. You know, people got their exercise by their daily activities, not by doing exercises. And so they don't know what to do, and they may already feel like they have enough to do without having to add exercise into the mixture. And if it's a spouse, they may be more frail physically than their care recipient is. And so a lot of challenges faced with that. So one of the things, another area of research was just to look at, well, if we train home care providers to go to people's homes and work with caregivers and people with dementia and teach them an exercise program that's specifically designed to try to help maintain mobility, will they be able to do it? Will the caregiver be able to do it and get the care recipient engaged in that? And what will the outcomes be to that? And so we looked at this program where we compared that with a group that just got routine medical care. And it was a 12-week program and then followed by 4 monthly follow-ups. And what we found was that the exercise program included kind of a balance of aerobic activities, primarily walking for exercise, and then some strength exercises using cuff weights that you Velcro around people's wrists or ankles, and some balance exercises and flexibility. So and those are pretty standard for any exercise program. We tried to simplify them so they would be easier to understand. And then we also trained the health providers to do some problem solving with caregivers and kind of teach them how to be realistic about what their expectations were, how to convince their care recipient to engage in the exercises, and just to help them know what resources and supports that were available to them in the community. So it was a combination, caregiver educational intervention plus an exercise program for the care recipient. And what we found was that over time, the people who were exercising at least an hour a week, which at that time was a lot, now it's supposed to be a lot more than that, but that increased over time. And the dark colored is RDAD, which was our name for the exercise program, Reducing Disability in Alzheimer's Disease. And the lighter blue is the routine care. So after 3 months, we had a significant increase in the number of people who were exercising in our treatment group. And after 12 months, which remember they only had this program for half of that time, for 6 months, we still had a higher number of people who continued exercising. It dropped off over time, but there were still a significant number of people who were exercising. So one question that we had was, can you even do this? And this told us, yes, you can. And then we looked at daily activity functioning. Remember, that was another thing that's associated with quality of life, and how that changed as people engaged in the exercise program. And once again, for our group that got the exercise program, it improved over the 3-month time period, while those in our control group had a decrease in their daily functioning over time. And again, we see the same result at 12 months, just not quite as pronounced at that point. And then again, for depression, we looked at how does it impact depression. And in this case, having a lower depression score is better. So again, our treatment group got better. Our control group stayed about the same, got a little bit worse. And then over time, the treatment group was even better at 24 months follow-up. So it had a more lasting effect on depression. And then behaviors, and this was one of the findings that made the study really interesting to a lot of people. So we looked at why people were placed in nursing homes, because we followed these people for a long time. And so a significant number of them actually were placed institutionally. For people who were placed because of illness or cognitive decline was the same, whether they got our treatment or whether they were in the control group. Increased activity of daily living impairment was the same. But for people who were placed in nursing homes because of behavior problems, that number was much lower for the group that had been in the treatment program than for the control group. So we saw the exercise benefits, we saw the depression benefits, and then we see the benefits for caregivers just learning how to manage behaviors better as well. So again, looking at the take-home message for this, what can you do with your family or clients or patients to promote exercise? One thing is to just explore with them what have they done in the past. And I wouldn't necessarily even call it exercise. I might say, well, what kinds of activities have you done before? What did your husband always like to do? And figure out what those are, and then provide support and assistance for engaging in those activities, or if you're going to do a group program, to provide. We have an exercise program now that we're doing in a group where we use buddies, exercise buddies, so that people have a family member or friend who does the exercises with them. Monitor them for safety. Make sure that the exercises are simple. I would recommend not using a lot of unfamiliar equipment, because it's just something else to learn how to do. It's both distracting to the person with dementia, and it can potentially be unsafe. The best exercise that we've found, and the thing that seems to be the most sustainable and have the most long-term effect, is that daily walking. And so getting caregivers out to walk every day with the care recipient is good for both of them. And then how can you make it a pleasant event? When we were doing the RDAD study, we talked with caregivers about, well, how do you get your husband to walk? Sometimes it was to take the dog out for the walk, or to walk to the coffee shop, or to go to the playground and watch the kids playing, or to have a certain destination in mind. So just incorporating pleasant events into that. And then the fourth area of psychosocial intervention is supporting caregivers. And remember, we talked about caregiver burden and depression having an impact on the care recipient's quality of life. And just an example of this is from a study a while back that looked at how many hours per week people spent caregiving. And this is the primary family caregiver. This is the second bar is the amount of paid help, the hours of paid help that people got. And then the lighter blue bar is other family and friends and how much time they contributed. And what you can see, the main take-home message from this slide is that the primary caregiver really carries a heavy burden of care. And even when they have other people coming in, the hours that they're spending is still really huge. And even those who are employed full-time, besides working their 40 hours a week at their job, are coming home and spending another 60 hours a week providing care. So it's like the equivalent of another full-time job for them. And so, you know, we know that caregivers experience a lot of changes in their own lives and in their relationship with the care recipient that influence those feelings of depression and burden that they have. And it can, like the arrows indicate, it can kind of become a vicious cycle where you're worried, you're not sleeping well, you're grieving because you're losing the person that you've spent your life with, or a parent or somebody that you really care about. And so caregivers can get into this cycle of that really contributes to their feelings of depression and burden. And so again, looking at, well, how can we provide caregiver support? And this was a study that we did primarily focusing on caregivers, where again, we worked with community consultants. These were home health workers or counselors in the community to work with family members to improve dementia care. And this was another randomized trial. And we call it STAR C, STAR Caregivers, or STAR C. And this is what the intervention is. It's 8 in-home caregiver counseling sessions, focusing on a variety of different things to help improve caregiving skills and also help caregivers to learn to do self-care for themselves. We use a problem-solving strategy that I think next week David Lafaja is the speaker, and he's going to talk a lot more about this because it really applies particularly in later stages of dementia, but I'm just going to touch on it here, where we know that problem behaviors or problem moods can interfere with your ability to care for a person who has dementia. And so we teach caregivers this process of ABCs. What's the behavior that is occurring that is disturbing? What is it that activates or precedes that behavior? What's going on when the behavior occurs? And then what are the consequences? So for example, one of the things that one of my patients was, or my clients was doing, was picking at the carpeting, and it was an anxious behavior. So it was driving her husband crazy because she was down on her knees picking at the carpeting for, you know, long periods of time. And so he looked at, well, what's going on before she starts doing that? And really the answer was there was nothing much going on, that she was kind of just sitting on her own. Something would catch her eye, and maybe it was a piece of lint that got her started, and then she would just keep on going and going, and she's pulling the yarn up out of the carpet. And what was the consequences? And he would go in and he would try to get her to quit doing it, and she would get upset. So vicious cycle. So we looked at, well, how can we change that? When you see that she's starting to get restless in the chair, or when she first goes over and picks up that one piece of lint, what can you do to engage her in some other activity? And here's where pleasant activities come in again, too. If we have a list of those on the refrigerator door where he can just look at them and see them, then he has lots of alternatives to try with that. So that's really what the ABC strategy looks like. And then we work with the caregiver to develop a written plan if that appeals to them, and just look for where can you break that chain of events, because you can break it in several different ways. You know, there's lots of different approaches. And using that approach, we looked at how that had what impact that had on caregiver depression. And again, we had the treatment, and then we had routine care as our control group. And here we see again that from baseline to immediately after treatment, caregivers had a significant drop in their depression scores, which they were able to maintain over time. So I think this is again 3 months and 6 months. Where for the routine care group, their depression increased over time as the problems that they were dealing with also increased. And we saw exactly the same pattern for caregiver burden. and for caregiver reaction to behavior problems. At the beginning of the study, caregivers would get pretty upset when their care recipients started picking at the lint or crying or whatever it was that the behavior was that they were targeting. By the time they finished, their level of upset really declined a lot. So learning how to do problem solving, just identifying the ABCs and substituting alternative behaviors for the ones that you want to change, had this much of an impact on the caregivers. And interestingly, now to bring it back full circle, changing the caregiver's depression, burden, and reaction to behavioral disturbances resulted in improvement in the care recipient's quality of life. So by helping caregivers cope better, we saw an improvement in the care recipient's quality of life, where our routine care folks stayed about the same over time. And you know, when people ask me, well, what's the thing that makes the biggest difference in dementia over the whole span of cognitive impairment, caregivers are the most important thing, more important than medication or anything else. The caregiver really is one of the keys to maintaining quality of life. And so helping them to develop the tools that they need to do that is really, really important. So now I want to spend the last part of my time just kind of giving you some creative ideas of what are the future developments or what are the future directions in early stage memory loss planning. And I know some of you live in communities, those who are commuting in for this, you may live in a community where there maybe aren't a lot of resources, and you think, well, in Seattle it's easy to do that, but what can we do? Well, you know, a lot of these things, even if they're a group approach, they can be adapted to individuals as well. And there are many different strategies. So part of what we need is just to have a lot of variety for people, particularly in the early stages of dementia, while they're still able to participate in these activities and they want to. In terms of what we have the best research support for, as I've described to you already, counseling and support groups really have the highest level and the best amount of research support. And once again, I've given you some names of people who have developed programs and done research in these areas so that you can look them up if you want to get more information about them. Physical activity for people who already have cognitive impairment, we see some mixed results with that. The work that we've done here suggests that it does improve many different areas, but there are some other studies that have not found those kinds of results. What we do know is the results that I already showed you from the RDAD study, and then my colleague here, Sue McCurry, who I think also, is she coming to speak to, has developed a really nice walking program where she's shown that it improves sleep in people who have dementia. So that daily walk and light exposure can improve sleep for people who have dementia, which is no small improvement when you're their caregiver. Cognitive rehabilitation, you know, you hear a lot about cognitive rehabilitation and computerized programs and other things to help to keep your brain functioning better. And those really have mixed results for people who have dementia. The ones that are on the computer are usually not very successful because they're too complicated, even for people with fairly early stage dementia. Ones that are done in person have better results. And this group, the first one that I have listed, is in England, and they've done quite a bit of work and have some of the most promising ones that I've seen. The downside of the cognitive rehab programs is that the results are often fairly short-lived, and they may have an impact immediately, but whether they generalize to other areas of functioning is unclear too. It may be caregivers may actually benefit more from the cognitive stimulation kinds of things than the care recipients do. And then other more creative kinds of things that you might think about in your communities, and think about who you can partner with or who you can work with to make programs that maybe are there for older adults in general and make them more dementia friendly so that people who have memory loss can continue to participate in some of those programs. Some of the ones that I think are promising in that area are these arts programs where a lot of art museums have developed programs where either they have a gallery tour where they invite people to come in regardless of cognitive impairment and kind of take them around and lead a discussion of a particular piece of art or do an art making activity. Photography has been used successfully with people with early stage dementia, and photo voice is a specific technique where people go out and take pictures that represent something to them and then bring those pictures in and talk about it. And what Dr. Atai did in this study was gave people disposable cameras, told them every day go out and take 2 pictures, and she had a fairly sophisticated system for reminders for people to help them remember to go out and take their pictures. And then they would come back and talk about what those meant to them. And really interesting and very insightful comments from some of the people with dementia. Choirs are becoming more popular, both just choirs for people who have dementia, but a lot of senior centers and other places are developing choir programs, and ability to sing and remember words can definitely be retained for a long time as people's cognitive ability declines. Drama programs, storytelling programs, there are many different creative ideas. There's not a lot of empirical research on these things, but qualitative research where they ask people, what is it that you enjoyed about these programs? People are very enthusiastic about them. Intergenerational programs where people are, especially, probably the one that has the most evidence now is partnering people who have dementia with medical students or students in other areas for a period of time so that they might do a certain activity together or go to one, say partnering somebody for an arts program or an exercise program. And those have shown that they really have I think they have more of an impact on the medical students than they do on the person with dementia, but the benefits to both people. There also is a study looking at, or an innovative kind of clinical program, really looking at daycare, and this is daycare for kids, for children, that is associated with an assisted living facility, so that the older adults have a time every day where they engage with the kids and, you know, develop relationships, and to the mutual benefit of both the little kids and the older adults. So what are the recommendations for early stage memory loss programming that you might take home with you or practice in your communities? One, I think, is to remember that everybody's different. Not everybody wants to go to the art museum. Not everybody wants to sing in a choir. Not everybody wants to be in a social group. But people like to have variety and like to have choices, and some people will do anything that you give them. There are people here in Seattle who I see at every single early stage program that we have. And then there are others who kind of pick and choose what they want to do. I think if you have a group of people who have early stage dementia, involving them in planning what these programs should look like can be really useful too. One of our senior centers has, with input from the members who are in their early stage program, they've developed a book club. And probably many of you have heard about Alzheimer's cafes or gathering places or other kinds of programs that are more informal and just kind of out there in the community. For programs that are designed for older adults in general, you can often really help people with memory loss to engage in those programs. And especially if a spouse or partner is attending the program, they can bring their care recipient with them if there is memory support. And sometimes it's as simple as having visual aids available. having handouts or recordings that they can take home with them to listen to. So a lot of those things can really facilitate participation in individualizing the programs. I think making existing programs accessible. I talked about creating new social networks like coffee time or other more informal programs. And then looking at how you can develop volunteer programs. Meaningful activity is important to a lot of people. And feeling like you're engaged in something that is meaningful and that is helpful to other people can really help improve mood, self-esteem, feeling of worth in those individuals. And for something like putting food into bags at the food bank, people with early stage dementia can do that, no problem. You know, things like making blankets for the dogs at the animal shelter, people can do that, those kinds of things. So looking for volunteer activities that you might get your group engaged with is really helpful. And then my take-home messages. Quality of life as perceived by the person with dementia doesn't necessarily decline because of memory loss. It declines for other reasons. It's strongly influenced by mood. And it doesn't have to be clinical depression. It's just depressive symptoms can have an impact on quality of life. And we found, and I hope I've demonstrated to you today, that mood is influenced by pleasant activities, exercise, and social support. And that family members, friends, and other caregivers, including all of us, can really have an impact on quality of life for people with dementia. And what we found was that what's good for the person with dementia is also good for the caregiver, and vice versa. You know, it's really a dyad. And in my final take-home messages, go Seahawks! This is my granddaughter who's 2 months old. And she's watching the Green Bay game there in the background. So I expect that some of you have some questions or comments, and so I'll just stop there, and we have about 15 or 20 minutes left. Oh, yeah.
So if you have questions here while the chat gets started, please feel free. You'll probably need to repeat their question.
Okay. Any questions from our live group? Or comments?
I'll start with something. You know, in the last 10 years, home care, the quality and really the quality of home care has been increasing more and more and more. We know that the baby boomers, as they come online, that trend is just going to continue in leaps and bounds. And so, what do you think the future is for? You know, right now the home care that's being provided is ADLs and toileting and you know, maybe some cooking, but you know, the exercise piece, which you talked a lot about, and then training and working with the family caregivers. Do you see that? You know, because people are aging in place, they're not, you know, going out to communities as much, and those that are, I'm seeing they're older and frailer coming in. So, what do you think? Your opinion of additional services that can be provided in a home type.
Good question. Barb, do I need to repeat that for the remote people? Okay. So the question was about home care and the observation that more and more people are getting older with us baby boomers. Yeah. And it's most people's desire to age in place, to be able to stay at home for as long as they possibly can. And the group who makes that possible is home care workers who are going in, and primarily now the focus is on assisting with ADLs or dressing or bathing or house cleaning or those kinds of things. And so I think the question really was, is there a role for home care workers in engaging in some of these kinds of interventions that we talked about, correct? And, you know, I do see that. And one of the things about all of the programs that we've developed, and I think that other places have developed, is that they start off being delivered by, you know, PhD clinical psychologists or nurses. And what we work on over time is how can we train people who are actually there doing the hands-on care to do it. And we've worked a lot on training the family caregivers to do it. And so now the next step in that process is training the home care workers. And, you know, I think that it depends on, there has to be a good match between the skill level of the home care worker and the complexity of the intervention. So for things like exercise and engaging in pleasant events, I think home care workers really can play an important role in making that happen. And for things like behavior management and the ABCs, I think that takes a different skill level. And so I really do think that what we need is people across the spectrum of care providers to do different kinds of interventions. But yeah, and I see that being, at least in the state of Washington, being incorporated more and more into the training that's required of those home care workers, that even the people who are doing the basic ADL care are getting training in behavior management now, at least, and understanding what it is that causes behavioral disturbances and how to do that. And, you know, the idea that perhaps those individuals could be taught to enrich the environment or to provide additional assistance. I think that's a really good area and something that we're really going to need. I see we have a lot of questions coming off.
Someone has asked what does STAR and RMC and SCD stand for?
Okay, well, the slides that I showed you, there's STAR, which is staff training in assisted living. I think it started off with it as an assisted living program, and we modified it for caregivers. So it's STAR C is just our behavior training for family caregiver program. The RMBPC, is that one of the things?
It was the RMC, which I think you said was routine.
Oh, routine medical care.
And then it said SCB.
Screen for caregiver burden, probably. You know, I'm sorry, I should put a glossary on the end of the slides when I abbreviate things. I do that to make the diagrams and tables a little bit simpler to understand.
Do you have a book or a list of the different activities for clients in different stages?
You know, I don't have a book. I have some lists, and I can give those to Barb so that she can put them on the website and people,
and send them around.
Yeah, or send them around. Especially the list of pleasant events. The pleasant event schedule, I think, is really helpful to people. But then if you also look at programs that are developed by occupational therapists, they have a lot of ideas for things to do with people who have dementia. And so, you know, just be creative and look at those kinds of things too. But the best way to develop a list of activities is to look at what the person themselves has enjoyed doing in the past. And the pleasant event schedule just gives you a place to start with that. So we can make that available.
Are the person's challenges regarding exercises mainly due to the loss of ability to learn as a cardinal feature of Alzheimer's disease and other dementias? The challenges with doing exercise?
The challenges with exercise, yeah, I mean, there is eventually some physical decline that's associated with Alzheimer's disease and other dementias, but the first problem with it is that ability to learn new information, to follow more complicated movements, and to remember to do the exercise. A person who has been a habitual lifelong exerciser is more likely to be able to continue doing it, where if it's all new to somebody, it's going to be more difficult. So that's one of the reasons too why we look at what it is that people have done in the past. So, you know, if somebody's been a golfer in the past and they've quit doing it because they just can't get to the golf course and can't figure out how to do that, then we might work on, well, how can we make that happen?
Missoula's asking if you can elaborate on ways to balance out the negatives, such as reminders for pills, that kind of thing, with positive, pleasant activities. Caregivers have to continue to remind about pills and can't always be positive all the time.
Right. And, you know, I think part of that is, it is a balance. And I think where we run into problems is where it becomes all negative interactions. So especially as dementia progresses, not so much necessarily in early stage, but, you know, well, no, you can't, you have to take your bath now, or no, you can't go out now because I don't have time to go with you, or whatever. And so when there are things like reminders of pills, or having to go to the doctor's office, or to do things like that, if you can pair them with a positive activity, then that can also make it more palatable, or giving people a choice about when and where they do something can make a big difference. So I would just say, look at how you might adapt the approach so that it is more acceptable to the person as well.
How frequently have you found that persons who had dementia discovered early wish they'd never known?
That's a really good question, and I don't know that anybody has actually done much research on that. You know, I think that, like I said, there are positive and negative aspects of having a diagnosis of dementia, and especially early on. And I think that it's an individual thing, too. I've had patients in my clinic say, if I have Alzheimer's disease, I just don't even want you to tell me. But more often, I find that people do want to know, and I do think that it's empowering to people. I think that the people who say, I wish I had never known, are ones that maybe they get that diagnosis dropped on them and then no follow-up. You know, well, sorry, you have dementia, there's nothing we can do about it, you should go out and start looking at nursing homes. Well, most of us would have a negative reaction to that. So that's very different than, you know, it looks like you have early dementia, let's start working together to make plans, and I'll have you come back next week and we'll talk about what you need to be doing in terms of, you know, changing your activities, or how can we keep you functioning as best as possible for the longest time. Because I think that knowing really gives you the opportunity to maintain your functioning for a longer time, too, if the clinician is skilled at doing that.
The Alzheimer's Resource of Alaska in Fairbanks asked the question, but I'm going to ask you folks in Fairbanks if you could repeat the question, because I'm not quite sure what you're asking, and while you're doing that, I'm going to move on to another question. Is there a specific assessment tool used looking at ADLs?
There are a lot of different tools looking at ADLs. The one that we use most often is called the Lawton-Brody Instrumental Activities, ADL and Instrumental Activity Daily Living Scale. But, you know, I think a lot of states in their dementia services programs, they have tools that they use to look at ADLs and activities of daily living, such as dressing, bathing, toileting, ability to eat. But especially with dementia, and especially with early stage dementia, it's the more complicated things too. Shopping, taking medication, driving, those are all activities of daily living too. So what measure you might want to use kind of depends on the purpose for it and where the person is along the progression.
Okay, and someone asks about repeating the question for the outlying listeners, but I will mention to you that I'm mic'd. So if you can't hear me, please let me know, because you should be hearing me. And then Rebecca has been repeating questions that come from the room. A question is, are you familiar with the Eden Alternative and Eden at Home by Dr. Bill Thomas?
I am, and I think that that's a good example of how to individualize a program and provide pleasant activities and to create an environment that really facilitates functioning.
Did the results of ESML seminar benefits to caregivers show no significant improvement in perception of emotional support? The graph looks as if that were so. Any ideas why?
That is correct in that the support group study, the caregivers, the care partners who participated in that study did not experience any change in their functioning as a result of participating in that program. Now, I think it's important to realize that these were early stage caregivers and that most of them did not really even identify themselves as being caregivers. We call them care partners, and now we call them study buddies because they really don't consider themselves to be caregivers. So part of the reason for that is just that, you know, if there's not a level of distress, you can't really show improvement. But I think the other thing is that the groups were really designed for people with dementia. These are not caregiver support groups. These are support groups for the person with early stage dementia.
Kenny Lake says there's a great book called Alzheimer's Activities, Hundreds of Activities for Men and Women with AD and Related Disorders by B.J. Fitzray. There are detailed lists of activities under various headings. It's great for priming the pump.
Great, good. And maybe, is that something you could send out to people?
Mm-hmm.
So the person who asked that question would have that resource, yeah.
And I don't have any other questions from the chat. If there are other questions in the room?
Well, I would like to ask a question to our outlying groups. And, you know, I know that here in Seattle, we have an abundance of resources for people with early stage dementia. And we do have the ability to get people together and form groups or programs. And, you know, I just wonder if that's an issue in more rural areas, and how have some of you dealt with that or developed resources for people who have, you know, just not severe dementia, but early stage dementia, who are just starting to cope with that. Any suggestions or ideas from out there?
Powell Valley says we have a caregiver support group for all stages.
Yeah, so caregiver support groups are really helpful, and when it's caregivers, you can really kind of include people at all different stages. One of the things that we've been looking at here is we have a lot of adult day programs and adult day health programs that tend to attract more moderate to severe stages. And I think it's really a challenge to figure out how to make some programs that are attractive to people earlier in the process, because I really think that the sooner people start engaging in those, the better off their long-term effects are going to be.
Kenny Lake also says it is a real issue in the rural areas. Mm-hmm. The Alzheimer's Resource of Alaska asked about what website did you refer to posting something, and we'll post it up on our Northwest GEC website with this talk, but I will make arrangements for it to go out to your site coordinators as well. So check in with them within the next day or so, and they should have a copy of this additional information.
Mm-hmm. I see that Kenny Lake says they've been providing online webinars and phone support groups for anybody in the state. So, you know, I think that that's a really great idea and resource to kind of get people connected. And especially, you know, as the next generation ages, and we're used to using our computers for a lot of different things. And I think that more and more those online kinds of support programs are going to be attractive and available to people.
Kenny Lake also says they do the Savvy Caregiver class as a webinar.
Mm-hmm. Yeah, I'm really impressed with how well webinars can work. And they can work with people who have early stage dementia too. So I think that one of our the people in our early stage resource group actually created the website there's a program in Seattle called Dementia, which is people with early stage dementia, and the creator of that website is one of the members of that group.
Alzheimer's Resource of Alaska says in the Anchorage area we have support groups for caregivers and specific groups to do art activities for early stage dementia individuals.
Yeah, great. You know, I think that, and like Barb said, I've been involved with the Fry Art Museum here doing an art activity program. And I think that one of the benefits of these arts programs is that they're more accessible to people. my program, I was a care partner for somebody that didn't have, or I was a study buddy for somebody that didn't have a family member to do it. And, you know, there were sometimes the person with dementia was a much better artist than the care partner was. So, you know, there's kind of a reversal of the usual relationship and a newfound respect for people's abilities as well. So I think that's really great.
And, you know, an ongoing issue in Alaska is that it may be an issue getting to those groups for weather issues, but they have a regular number of attendees.
Mm-hmm.
I wonder if you want to talk with them a bit about the conversation cafes that they have here in town.
Right, yeah, you know, I think that, and the conversation cafes, I think they started off being called Alzheimer's cafes, but that kind of put some people off, so now they are looking at different names for that program. But, you know, it's just kind of an open-ended program that people come, and they're in cafes or coffee shops. They're not in senior centers or Alzheimer's offices. They're out in the community. And usually there's some kind of, there's not a lot of structure. Usually there's something going on there. People, you know, bring their musical instruments and play them together, or they might decide to talk about a book, or they might just come and chat with other people there. So, you know, having that, it's a fairly low cost, low resource activity that is, you know, it's like normal. We all want to go to the coffee shop and meet our friends. So I think it's a really nice thing to do.
So I will make arrangements to have the schedule, you call it schedule of pleasant
event schedule,
okay.
Yeah.
As well as this book that was mentioned here, sent out to the sites. And I think we're done, and thank you so much, Rebecca.
Yeah, and you know, out to the sites, if anybody would like more information about the interventions that I talked about today and that David's going to talk about next week too, we have manuals for all of those that we'll be happy to share with people, or other materials that we have, so just let us know.
There's one more question if you could pick it up. About night care centers, nighttime care.
Oh yeah, have there been any studies about the use of nighttime care centers? I don't think there have been any studies of that, but I think it's a really great idea. And you know, there aren't a lot of them available. I think that people have tried to get some going, especially for people who are awake a lot at